welcome everyone to the Anne Klibanski Visiting Scholar Lecture. My name is Miriam Bradella, and I'm the director of the Center for Faculty Development. And in today's sessions, Dr. Jennifer Rymer from Duke University will be talking about challenges in performing research in patients with peripheral vascular disease. So now I'm very excited to talk a little bit about the Anne Klibanski Visiting Scholar Award, which we initiated here in the CFD at the beginning of the COVID pandemic, which was disproportionately affecting women. And even before COVID, women were less likely to be visiting professor because of challenges related to travel. If you have children or ailing relatives you have to take care of, it's very hard to leave for a week to give a talk at a national or international institution. So we used the silver lining of the COVID pandemic, which was that now a lot of grant rounds in visiting professorships are conducted virtually. So far, we have identified 99 women faculty, clinicians, educators, researchers, and postdocs at MGH who we thought had exceptional promise as leaders in their field and would benefit from a national or international speaking opportunity, receiving mentoring and networking opportunities at that institution. So the award entails for the Center for Faculty Development to organize this lecture, but also the scholars receive mentoring, professional coaching, and leadership training. The award is named after our CEO from MGB, Anne Klibanski, who was the former director of the CFD, my predecessor, and the former head of the neuroendocrine unit. And she was a very successful NIH-funded researcher before she became CEO and a very strong advocate for women, establishing the Claflin Awards for Women Faculty and the MGH Backup Childcare Center. So this is our first cohort of Anne Klibanski Visiting Scholars. This is a great picture of our diverse women faculty and postdocs. This is the second cohort, and now we're in the third cohort. And we are actually now accepting application for the fourth round. And we just sent out an email. The deadline is May 15th. So I cannot do this alone. We have amazing, what we call champions. These are faculty members who actually are sponsors of our women. They pick up the phone, they send out the email to their networks to organize these lectures. And then we also started the visiting lecture series to advance the careers of as many women in the US and abroad. And we invite the women of the host institution who hosted our scholar to give a lecture here. And these lectures are open to the MGH community and the one of the host institution. And we really hope to foster collaborations across institutions. So here's just an overview of some of the institutions where our scholars have lectured. And I want to highlight Duke University, the alma mater of our lecturer today. So actually, this is the last cohort, and Dr. Emily Lau, one of our current Anne Klibanski scholars, will now introduce our speaker, Dr. Jennifer Rymer. Emily, the microphone is yours.
Thank you so much, Miriam, for introducing the Anne Klibanski Scholars Award. It's been a tremendous program. And I'm especially delighted to be introducing our Anne Klibanski Visiting Scholar, Dr. Jennifer Rymer. Dr. Rymer is an interventional cardiologist and the inaugural John Bush Simpson Assistant Professor of Medicine at Duke University Medical Center. As an interventional cardiologist, she specializes in peripheral vascular interventions and complex percutaneous coronary interventions. Dr. Rymer is a member of the esteemed Duke Clinical Research Institute, and she's the principal investigator of the multi-site Cangrelor and Acute Myocardial Infarction Effectiveness and Outcomes CAMEO Registry. Dr. Rymer completed medical school and a Master's of Business Administration at Vanderbilt University and a Master's of Health Sciences from Duke University. She then went on to complete residency and chief residency in internal medicine at Duke before going on to train in general cardiology and interventional cardiology, also at Duke, where she was also selected to be chief clinical cardiology fellow. Dr. Rymer is an absolute star. She's been awarded numerous clinical and research awards, including the Robert Harrington Award for Excellence in Clinical Research at the Duke Clinical Research Institute, the American College of Cardiology William Keating Career Development Award, and the Women as One Escalator Award, among many others. Dr. Rymer has been a very long-time role model for me, a mentor, and a dear friend, and it's very special for me to have her join us today.
Thank you, Emily. What a kind introduction, and I would say I feel the same way about you, and had such a delightful time getting to know you over the past couple of years. So I'm so excited to be talking to you all today about something that's really near and dear to my heart, which is challenges in performing research in patients with peripheral vascular disease. This is something that I have formed the basis of my career and a lot of my research over the past 4 to 5 years, and I'm excited to talk with you all about where I think the field is going. Here are my disclosures. I'm from pharmaceutical and industry grants. I am currently on a AHA CDA and in transitioning to a K23. So I want to set the stage before I start this talk and help you understand why this is important to me and why it should be hopefully important to you as well. So this is a look at lower extremity amputation rates in North Carolina. And this is older data, but in fact, I looked over the past week and it hasn't changed. It's a county level view of amputation rates. Now I live in and around the Durham and Wake County region, which is the middle of the state. And I have a big red arrow in the Franklin and Warren County regions. And this is where I go weekly. So I practice in the Duke lab and do interventions there, but then I also go to Franklin and Warren County to work at a hospital that up until a couple of years ago had no vascular surgery, no vascular medicine, and no real access for patients coming in with peripheral vascular disease to get interventions and hopefully limb salvage. And this experience, taking care of a majority population there, majority African-American patients with very little access to care, has really helped to solidify my passion in this area. And I hope that that comes across today. So I want to also start off in talking about the PAD belt before we even talk about the agenda today. And I hope you guys will look at this map and sort of ingrain it into your mind. So think about where our traditional research sites are located. They're in large metropolitan areas, large academic centers. You all can name them just as well as I can. But now let's look at this map here. And this is, again, amputation rate across the US. And you can imagine you can draw a line from Texas all the way through Mississippi into the Southeast and Tennessee, North Carolina, up into Virginia. And this is called the PAD belt. And I practice in part of the PAD belt. This is where a lot of our patients are. Certainly there's many in the Central Atlantic region, some in Oregon, and some in the Northeast. But as you can imagine, and what I hope to show to you today, a lot of our research sites don't exist where the PAD belt exists. And I hope I can make you understand why we need to change that paradigm. So my agenda today is I want to briefly talk to you about epidemiological patterns in PAD care. Even as cardiologists, I find that a lot of really experienced cardiologists don't understand or maybe not aware of a lot of the patterns available or present in patients with peripheral vascular disease. I then want to talk about the current state of participant representation in PAD research, the challenges that I've faced and I know others have faced in PAD clinical research. And then what are the strategies? So how are we going to fix this? What's the next generation of PAD clinical trials and registries? What's that going to look like? So let's start off with epidemiological patterns and disparities in PAD care. So many of you all are probably familiar that, as in most atherosclerotic diseases, it becomes more prevalent with increasing age. And that's certainly true of PAD. So about by the 7th decade, certainly through the 8th and 9th decade, PAD is increasingly prevalent, as you can see here, mostly matched male to female, although you can see as patients and participants become older, there's a higher female prevalence and predominance of PAD, but it is a disease of typically older individuals. Racial and ethnic prevalence, so as you can see here on the left, the rates of PAD are about twice as high for Black men after the 5th decade. You can see this compared to non-Hispanic whites or Asians. Now for women, there is a prevalence again of African-American women, but also for Hispanic women as well. And I'll talk to you a little bit about the Hispanic paradox within PAD. It's oftentimes noted, but do also know that there is considerable number of women that I see in my clinic with PAD who are Hispanic women. Now, ethnicity and race and PAD, so you can see that by virtue of being a Black patient, you have an odds ratio of 2.34 compared to a non-Hispanic white for having PAD. And this is very, very important because, as I'll show you later, unfortunately, the representation of Black patients and participants in our clinical trials, even our contemporary ones, is extraordinarily low. So keep these in mind. And certainly, I know this is data from 2005. I will update any sort of data in terms of prevalence here to show you that these numbers really haven't changed. Ethnicity and PAD. So you can see in the South, that is where the predominance of PAD exists. So 41% Caucasian in the South, almost 60% African-American, 43% Hispanic. So it's by and large a disease that is very heavily present in the South, certainly in other regions, but particularly among African Americans in the Southern USA. Now, this is an important slide to me, PAD prevalence and education level. And you may look at this and say, well, this is obvious. This is present in many disease states. We know that education level being lower is oftentimes, a marker for it being more prevalent, a certain disease state being more prevalent. But why is this particularly concerning for PAD? Peripheral vascular patients rarely ever just have peripheral vascular disease. They have chronic kidney disease. They oftentimes have diabetes. They're smokers. They may be on dialysis. They have concomitant coronary artery disease. They have all of the comorbidities that you can think of, and they have them all at the same time. And so now you've taken a patient that has all these comorbidities and then has a very complex disease like PAD, and you're putting them on many, many medications, and you're having nuanced discussions with them about their PAD, and there's not necessarily the literacy to understand those nuanced discussions. So this is a really particularly concerning element, I think, of peripheral vascular disease epidemiology. So let's talk about a little bit about clinical presentation. As I've said before, there's an increased prevalence of common risk factors, including hypertension, chronic kidney disease, and in ESRD among Black and Hispanic patients. Both groups, unfortunately, are significantly less likely to be initiated on statin therapy to achieve lipid-lowering goals. And even after controlling for CV risk factors, there is still excess morbidity and mortality among Black patients. And then, as I've mentioned before, though there's a higher risk for many of these CV risk equivalent factors, we know that PAD prevalence is not commonly higher in most Hispanic groups overall, though I did show you a little bit higher in women compared with men. So the Hispanic paradox is what I'm describing here. I'm going to talk a little bit about disparities, and then we'll get to a trial and registry representation. So disparities in statin use. I see patients every week that have had peripheral vascular interventions, they've had open surgical bypass, and they're not on a statin. And stop for a minute and think about, at your institution, if you discharged a patient who had had a PCI, who had had an acute myocardial infarction, or had had bypass surgery, not being on a statin therapy. And why does that exist? That never exists, right? We hardly ever see patients, hopefully, that are not on those therapies after those interventions. It's because the algorithmic care of coronary artery disease has not caught up to this disease state. So additionally, we know that the rates of statin prescription are up to 42% lower in Black patients compared with non-Hispanic whites. And this is after adjustment for age, hypertension, LDL level, and total cholesterol level. So big opportunities here for most prevalent population to be treating them accordingly. Now, what about disparities in revascularization? I think that this is, sometimes the most obvious things need to be highlighted. So we're looking at all inpatient revascularization, outpatient revascularization, and all vascular medicine care for patients. And as you can see on the x-axis, this is regional intensity of vascular care in the year prior to amputation. And then on the y-axis is regional amputation rate. And it's probably not surprising that if you have more intense regional vascular care, your amputation rates are lower. But just keep in mind what I've just said, many of our patients live in the PAD belt and don't have that access to care. And so this remains a big issue, is oftentimes patients are being sent straight to amputation, no stops for endovascular or surgical bypass, or even supervised exercise as being an option. So then you may say, well, the racial disparities exist because of the zip codes that many of our patients live in, because of the income quartiles, and because of the revascularization volume of these hospitals. And I'm here to show you a study that says that that's not true. So this was published in JAMA Surgery back in 2013, and it looked at the revascularization volume by hospital quartile. So the highest quartile has the highest revascularization volume at that hospital. And then by income quartiles, the highest income quartile, the richest hospitals or the richest zip codes that the hospitals are serving. And you can see that there remains, unfortunately, a significantly higher risk of amputation to be a Black patient at these hospitals, regardless of whether they live in the richest zip codes and regardless of whether they're going to the hospitals with the highest revascularization volume. And that is a concerning finding. And that's something that we have to, I think, socially talk a little bit more about why that exists. Now, what about disparities in outcomes? So what if Black patients end up getting revascularization? They should have the same outcomes. And that is not true. And so this was data from 2016 in the Annals of Vascular Surgery showing across the board, after amputation, after intervention, the risk of re-intervention-free survival and amputation-free survival significantly lower, unfortunately, in Black patients versus non-Black patients. And this is across the board, whether you talk about endovascular treatment, open treatment, surgical treatments, we see these same trends after adjustment for all of the common risk factors that we are concerned about. Now, what about socioeconomic status and amputation risk? So you can see here that despite socioeconomic status, the real identifier for risk of amputation is race again. And so Black patients, regardless of what their annual income cutoff is, have a significantly higher risk of amputation compared with non-Hispanic whites shown below. So a couple things I want to get into here. So racial heterogeneity in treatment effects. And so I want to talk a little bit about this because a lot of my work has been in patient-reported outcomes measures, and I'll talk about that in the next section. So in the CLEVER trial, so this was a trial of claudicants, lower extremity claudicants, with aortic disease, and they were specifically looking at various patient-reported outcome measures. Many of you are familiar with the short form 12 or the peripheral artery questionnaire for peripheral artery disease. And you can see that there was a differential in terms of if patients underwent revascularization in terms of supervised exercise or stent therapy. You can see here, for instance, for white patients, the SF12 increased only with stent therapy, and for Black patients only with supervised exercise. Similarly, there's a difference. Scores increased with stent therapy for white patients for the PAQ and for supervised exercise and stent therapy for Black patients. And I'll talk a little bit about why it's so important that we not be using tools that we haven't validated in certain groups, which we are currently doing. And so talk a little bit more about that. Briefly, sex differences. I won't focus so much on this because there aren't a lot of significant sex differences in PAD. So we know that women are typically older on presentation and oftentimes have more advanced disease and more comorbidities, and are typically less frequently offered revascularization. However, sort of across the board has been shown that women oftentimes have lower risk of MACE, so major adverse cardiovascular events and death. And the rates of major adverse limb events and acute limb ischemia are comparable between women and men. You know, and there's some studies that show some differences, but I think the real opportunity for peripheral vascular disease is even the playing field for Black patients versus non-Hispanic whites. And then briefly, let's talk about, before we move on, GDMT prescribing. So a lot of good data that exists out there that shows even after you've had an intervention, if you've been diagnosed with PAD, if you've been diagnosed with the most advanced form of PAD, which is CLTI or CLI, you're not getting GDMT in a lot of cases. So on the left was published back in 2020, and this was NCDR data and looking at patients on admission versus discharge. Very little change in class 1 therapy being prescribed upon discharge. Older age, being a woman, having CLTI and end-stage renal disease were factors predictive of being less likely to be discharged on aggregate GDMT. And I did an additional study published in JACC several years ago showing that even with a diagnosis of CLTI, unless you had a concomitant diagnosis of coronary artery disease, you were significantly less likely to be prescribed. And these are common medicines, statin therapy, a P2Y12 inhibitor, an ACE inhibitor, all of the medications that many of these patients, if not all, should be on. So the current state of PAD care and outcomes has a lot of room to improve. I personally believe that the coronary artery disease, we have really done a great deal of work to make a lot of the care algorithmic upon discharge. We still have some opportunities there for growth, but PAD is really the wild, wild west, and we have a lot of opportunities to improve care and outcomes. So what about the current state of representation in PAD research? So let's look at a couple of contemporary PAD trials. So many of you are familiar with the COMPASS trial, showed benefit for both CV and limb events with low-dose rivaroxaban in combination with low-dose aspirin for patients with PAD. And unfortunately, as you can see, for Black patients, less than 1% in several groups, and overall for the overall trial, only 1% were Black patients, nearly 16% for Asians, and about 22% women. For Voyager PAD, which is more recent, it showed a benefit of aspirin combined with low-dose rivaroxaban following lower extremity revascularization. Again, only 2% participants overall, Black Americans. And so I think a lot of room for improvement there. It's very difficult. These were excellently performed trials, but very difficult to generalize findings if the actual groups are not represented. Now, the BEST CLI trial, which has been recently presented, as many of you all are aware, which demonstrated that patients with adequate great saphenous vein conduit actually had a reduced risk of death when undergoing surgical versus endovascular procedures, and many other findings coming out of BEST CLI. But my main point is to look at representation. I think representation overall better in this trial than some of the other ones. You can see here just shy of 20% for Black participants, just shy of 30% for women participants. And I call that out to show that I think there's an increasing prevalence of sites, and this is the trial sites for BEST CLI. I think there's an increasing prevalence of sites in Texas, in North Carolina, and Tennessee, opportunities, I think, in the Southeast to improve there. But I think there's an increasing prevalence of going to sites that are not your traditional academic centers and trying to recruit patients from those areas. But there remains a big issue of underrepresentation. So this was, I think, a very interesting observational analysis of female participants from 2008 to 2020. And this was just looking at clinicaltrials.gov at various clinical trials that were registered there in peripheral vascular disease, in carotid artery stenosis, in type B aortic dissection. And in overall, if you have a PPR, and that's just the participant to prevalence ratio. So participant in the trial to prevalence of the disease in the local area. And if you have a ratio somewhere between 0.8 to 1.2, that's thought to be well represented of that subpopulation. Less than 0.8 is thought to be underrepresented. Over 1.2 is thought to be overrepresented. So across the board, and again, there's a lot of spread here overall, but for vascular trials between 2008 to 2020, Really, the PPR was 0.6 overall for women. For PAD trials, about 0.65, and for carotid artery stenting trials or stenosis trials, you can see about 0.6 and actually going down. So opportunities there, and I think an interesting way to sort of measure participation. This was another study looking at 200 cardiovascular clinical trials published in the what we think of as the largest journals: New England Journal, JAMA, Lancet. And then you can see the percentage of women in the trials in Black and the percentage of women among the population with the disease. And there's significant underrepresentation there, as you can see. Fewer women are enrolled in device trials and interventional trials overall. Fewer women are enrolled in CV trials with composite endpoints. And so why is this occurring? So many people will say women are statistically presenting with atypical features, more likely to be asymptomatic, more likely to have more comorbidities that may make them excluded based on the inclusion-exclusion criteria. And then also, and I think a major issue is that women are sparsely represented as site investigators and as clinical trial leaders. And I hope one of my messages today is doing and participating in clinical research is about developing rapport and relationships with patients so they trust you. And a lot of times that trust is best earned by seeing representations of yourself. If you're a woman participant, if you're a Black participant, having some diversity at the site, I think, is necessary. Same holds true for Black participants. This is looking at underrepresentation of Black participants, and this was looking at cardiovascular trials between 2002 and 2017. And you can see that the red boxes are those trials that have 25% or more Black participants during certain time periods in the trial. And you can see the very left-hand figure shows the percentage of the enrollment group within year group. And you can see the vast minority had greater than 25%. Now, what about those trials that defined a recruitment target? So I think that's starting to become a thing now. But as you can see here, the vast minority of trials developed a recruitment target. That requires having the sponsor, whether it be industry or NIH, say, we're going to cap sites and not let them put patients in unless they meet certain recruitment thresholds. And that's a hard conversation, but one we need to be having. And then the percentage of trials that met a recruitment target, you can see again, very close to zero, essentially. And unfortunately, as you can see here at the very bottom at the odds ratio, that the odds ratio for enrollment of 25% Black participants by time period has not changed over time. So really no change, no delta. Again, this is just another schema showing the PPR of Black participants for various cardiovascular disease states and trials and registries, less than 0.5 for most of these disease states. So extremely important. And this involves a hard conversation of why this is occurring. And I want us to remember that our social history and our history within the United States is not free and clear. We have exposed ourselves to creating the mistrust that oftentimes exists, I think, particularly in the Southeast. And it's important to remember our history, so A, we don't repeat it, and B, we can change a lot of the social infrastructure that exists in many of our research sites. So mistrust of the system, less likely to be approached for clinical research, oftentimes not, and that's the nuance, right? Those are the subtleties. That's where people are not being approached, and it may not be for good reasons. Lack of diversity in the workforce, and more likely to present with advanced disease and more comorbidities, oftentimes I think are the reasons for underrepresentation. Briefly want to talk about workforce diversity, and I think this is very important. If we don't have women and Black clinicians and Black researchers and Hispanic researchers, we can't have a diverse clinical research workforce. We need people in these areas that can go on to be our clinical research leaders. This was a publication in 2021 in the Journal of Vascular Surgery, just showing the underrepresentation in women across various surgical subspecialties. It's a little misleading, I think, for Black clinicians because there's so few actually in medical school that it makes it almost look like a one-to-one ratio when in fact they are vastly underrepresented for how they are represented overall in our population. One of my colleagues, Sonia Burgess, in Australia, published this in Circulation 2019 to demonstrate that among cardiologists and general surgeon, we won't reach parity for cardiology for women until past the year 2070 in terms of women versus men, where this has already occurred or will occur in the future around 2040 by current models for general surgery. So we have a lot of room to grow and a lot of opportunity to get women into cardiology and interested in this clinical area. And then just briefly, the drop-off is real. As you can see, we have fellows in training. So from internal medicine to cardiology fellowship, there's a significant drop-off, and then into the procedural subspecialties, another significant drop-off. So a lot of this is too complex to talk about in this general area, but I think we need to talk about it in order to know some of the strategies I'll talk about a little bit later about how to increase our diverse representation. Now, what about women in areas and women in leadership positions in trials? So this was looking at roughly 200 trials in New England Journal of Medicine, JAMA, and Lancet. And it was looking at leadership committees or leadership committee members in particular. Only 11% of leadership committee members were women. And then among the 200 trials, 41.5% without any female investigators and 55.5% of leadership committees without any female presence. And you can see that this is across the major trials, contemporary trials, that we have no female representation. And so, I saw a recent debate on Twitter. Well, why does this matter? Why does it matter if the site investigator is a woman or a man or what race or ethnicity they are? And it absolutely matters. And so I love looking back at this analysis published just last year. The proportion of women per trial was independently significantly associated with women participant enrollment. So, we can show this time and time again, but it is absolutely the case. Despite that, only 7% of trials had women as the first author, 8% as senior authors. So why is diversity important? I hope I've answered that. It's important for enrollment of our patients. It's important for the clinical care of our patients. And I think there's increasing evidence also that at least the perception of care and the rapport and trust that's built between the clinician and the patient increased when it's a concordant racial or ethnic clinician to patient relationship. So what about challenges in PAD clinical research? So I published a brief work about some of these challenges last year, looking at what I think are sort of the big ongoing issues with particular peripheral vascular clinical trials. Fragmentation of PAD care is a major one. So you can go from one county to another, one health system to another, and it may be vascular medicine, vascular surgery, interventional cardiology, primary care, wound care. Different people are taking care of the same patients in different health systems. So it's very difficult to sort of say we're going to target interventional cardiologists for our site investigators when in fact they're not taking care of patients in many of our locations. Heterogeneous local practice patterns, I'll talk a little bit about that. They're all over the place in terms of evaluation of these patients and then in treatment of these patients. Geographic mismatch between areas of PAD prevalence and traditional research sites. Trials still focus a lot on devices and intervention, very few on implementation. So we know what we should be doing right now in many cases in terms of medical therapies for these patients, but we're still not even implementing those basic practices. And then increased evidence needed for patient-reported outcome measures in PAD and then patients with a preference for medication versus intervention arms, and few patient advocacy groups for PAD. So I've been very fortunate to be a part of one of the few advocacy groups in the US for patients with peripheral vascular disease, Vascular Cures. They are, I think, very successfully bringing the patient voice to vascular trials, and are now a part of sort of the stakeholder groups for many of our clinical trials and registries. They were very interested in looking at the state of patient-reported outcome measures and intermittent claudication and CLTI, and we were able to publish this work last year. And so one of the questions I'm interested in why might there be a racial difference in perception of disease or quality of life among PAD patients? And so we know that, as I've shown you, Black patients have a much higher prevalence of PAD, and they have more advanced disease when they present. They're more likely to have an amputation after PVI or after an intervention, and to undergo repeat interventions. But yet, despite that data, and despite the fact that we see that quality of life perceptions differ across various groups, there's only been really one small previous study examining the changes in symptoms, physical limitation, and perceived quality of life by race. And unfortunately, and I think this is really important to keep in mind, all of these patient-reported outcome measures, ones used in Euclid, the ones used in Voyager, BEST, all of them have been validated in intermittent claudication, but not CLTI. So we're using a lot of measures that we don't know are actually validated in the groups we're using them in. And I make that point here is again, these are being widely used and they're very popular as sort of secondary endpoints, but we need to make sure we're actually understanding what they're measuring, and that we're actually understanding the disease states that we're measuring them in. What about patient-reported outcome measures and clinical endpoints in peripheral vascular disease? So I actually looked at some of these questions. Do they actually correlate? Are they associated with improved or worsened clinical outcomes? And so this was looking at some work from the Euclid trial, which you all are probably familiar with, and specifically looking at the probability of MACE and the probability of major adverse limb events. And as you can see here across the board, increasing scores, so higher scores are better on the PAQ, on the visual analog scale, and the utility scale, significantly associated with decreased risk of MACE and MALE at 1 year. So currently I'm validating many of these PROMs that are used in many of the clinical trials currently at Duke to better understand their performance, both in Black participants, but also participants with advanced CLTI as well. Another issue, I think, is geographic mismatch. And I'm going to talk about this as, I think, a strategy and how we improve PAD clinical research. So this was published by Rob Califf in 2014. And on the left, you can see the areas where there are clinical trials ongoing in the vascular space. The large black dots are where heavy areas of those trials are occurring. And then the amputation risk is on the right. And you can see that there's obvious mismatch, particularly within the Southeast and particularly within this PAD belt that I've highlighted earlier. And then there's changing landscape in how we're performing peripheral vascular care. So it used to be all in the inpatient setting, and now reimbursement has largely changed this, and many patients are getting even interventions in office-based laboratories out in the community. So it's important to keep that in mind. They're not necessarily coming to the hospital to get their endovascular procedures anymore. This is happening a lot in OBLs. And then heterogeneous practice patterns. This always is stunning to me. We actually looked at this in some more recent data in the past year, and saw similar trends. Up to 30% of patients do not get arterial testing prior to amputation in the United States. And that's really stunning. So patients getting endovascular procedures, getting amputations without any sort of evaluation of arterial disease, or if there's any possibility for intervention and limb salvage. And then the current state of antithrombotic and antiplatelet usage. So again, heterogeneous practice patterns post-PVI. So this is look at Medicare patients. This has become even more complex now that we have low-dose rivaroxaban. And you can see that in a cohort of about 85,000 Medicare patients, a fifth of all patients were not prescribed any antithrombotic after they underwent PVI. And then patients with operators that were radiologists or surgeons had lower odds of P2Y12 inhibitor use. And so there's a lot of different practice patterns of some people use Riva, some people use single antiplatelet, dual antiplatelet, 30 days, 6 months, really, really all over the place, and a lot of sort of lack of guideline support for what we should be doing. So overall, I've listed many of these challenges in recruitment for diverse populations in PAD trials. And I want to spend the last couple of minutes really talking about strategies to increase diversity. So, this was one of the few studies I think that was ever done to look at methods of recruitment for Black patients in a vascular trial. And this was published in Vascular Medicine in 2016. They sent patients various recruitment strategies, mailing, flyers, word of mouth, TV advertisements, and found that the most important strategy were mailings. However, that's one of the more expensive strategies as well. So how do we effectively reach the patients we want in these trials so that we're getting 30 to 40% and meeting the prevalence of the disease state within the actual community in the most efficient manner possible? So this is a recent initiative that I have worked on with various Duke colleagues. So Durham, North Carolina, and the Research Triangle Park has a coalition of historically Black churches. And if you think about our target demographic, which is patients aged 60s and 70s, predominantly Black participants, this is your target area, churches. And so we have partnered with various industry partners to bring around ABI buses and vans to screen patients and directly have them access care within the Duke Health System or the UNC Health System. And the next initiative that we're working on out of this new initiative over the past year is to get these patients plugged into research studies that are ongoing at the local site level once they've screened positive and once they've accessed care at Duke. So it's sort of this 360 approach. You get the patient in the community, you get them into the health system, you get them care, and then you also get them plugged in to research studies in their community for peripheral vascular care. This slide is courtesy of Mike Jaff, and many of you are probably familiar with the Elegance Registry, and I think there's a lot of learnings about how this registry in vascular patients, which is looking at sort of real-world data, post-market real-world data in a DCB and the Alluvia stent, how they were able to get such diverse population of patients within this registry. And it really was a lot about strategically selecting site investigators who are very diverse. And I think that was the big takeaway for me in my discussions with him was focusing on the diversity of the clinical registry leadership at both the steering committee level and at both the site level. And you can see that they were very successful in this. 20% Black or African heritage, 40% overall underrepresented minorities, and 40% women. So I think this is an opportunity, I think, for us to start thinking about the importance of registry and trial leadership. I have been fortunate to be very involved with the Best CLI registry. So it was an growth of the trial to try to capture a lot of the patients that wouldn't meet the inclusion criteria for the trial, but that were interesting patients that we should know about. We should understand real world experiences in management of these patients. And so in our recently proposed trial extension, we're now setting enrollment caps. And I think the threshold that is clear based on prevalence, particularly within the sites that we're looking at, is 40% women and 40% Black. And I know that sounds very aggressive, but that is the prevalence of this disease. And I think that is what we need to start aiming for. It does require the willingness to stop enrollment at the sites. And it also requires you to be very thoughtful about the sites you choose. You've got to study what their prevalence is in that area. You've got to use, if you have registry data like NCDR, VQI, you've got to understand what kind of patients those hospitals are treating before you put those sites in your registry. Even if they're very highly performing sites, they still might not be the right site for you. And you have to get buy-in from the industry partner. I've alluded to this already, utilize existing registry data sets. I'm actually at a sponsor meeting today where we're talking about being able to use national cardiovascular data, registry data to try to understand what sites are taking care of certain patients with AMI and other coronary artery disease. Traditional academic medical centers may not be the best source of a diverse patient population. I think we have to be intentional in recruiting women and underrepresented minorities as site investigators. We are engaging with Women as One, co-founded by Roxana Moran, to utilize their talent directory. And I know that there's other such talent directories to find new individuals for study chairs, ECs, steering committee chairs, and various positions on steering committees. So you've got to be willing to partner with these organizations, I think, to get new leaders. And then I think the future is this. So on the left is Duke University Medical Center, a snapshot. And on the right is the small hospital that I go to 40 miles away from Duke. And we have a LifePoint affiliate network of about 10 hospitals affiliated with Duke, but in the rural areas, we are able to utilize a central IRB in order to, it's sort of a hub and spoke model. So we're able to do research at these centers with our research staff at Duke, but then get patients from these centers into the studies that we're interested in. And now you're talking about working with a network of 10 sites under a simplified IRB mechanism and utilizing the research staff that you have at the hub, which is places like Duke, to help perform clinical research in the community where the patients are, not requiring them to have to travel back and forth. So this is overall how we fix the problem. It's a lot more complex than I'm alluding to here, but I think the main two places we have to start, and I think FDA and NIH are going to start to push us to have certain representation in trials in the future, and I think they're already doing that. So we have to consider trial leadership, diversifying that. And I think we have to consider these affiliate networks, these spoke networks as places of community partnership between large academic centers and start doing our clinical research, our registries, our trials at these local community centers so that our patients can be reached. So in conclusion, significant disparities remain in the management of patients with PAD. Disparities extend to the workforce and are not really closing gaps in those disparities, as I've shown. Lack of diversity in peripheral vascular studies remain even in contemporary trials, and we need a multi-pronged approach to improve diverse recruitment. And so I'll go ahead and stop there.
Wow, thank you so much, Jennifer. This was absolutely fantastic and fascinating, and someone who's doing clinical research, not in peripheral vascular disease, but in general in obesity. This rings so true. And we talked about a little bit before, we have to use our footprints in the community. MGB is expanding everywhere. So we have to use this for our clinical research. So thank you so much for this really inspiring talk. And I will quote this, and I loved your data on women and underrepresented minority trial leaders, including more diverse subjects. That's fantastic. I will turn it over now to Emily, who will lead the discussion. So thank you, Jennifer. It was a pleasure having you.
Thank you so much.
Thank you so much, Jen. That was a real tour de force and really incisive discussion on the challenges that we face as clinical researchers, and certainly really important innovative strategies to improve the diversity of our patient patients who are in our trials. I was really struck by the slide you showed that showed sort of how long it would take for us to reach parity in terms of gender representation in the cardiovascular workforce, and that actually that the surgeons seem to be doing a better job than us. And I wonder if you might have any thoughts and ideas about what lessons we can learn from our general surgery colleagues and how we can try to narrow that gap.
That's a great question. I think it's really multi-pronged. So I think it starts at the point of internal medicine residency. And I think Pam Douglas has been really a luminary in publishing in this area. And I think it's the messaging. I think it's, cardiology is a space for imagers. It's a space for operators, for interventionalists. You can really do anything within cardiology. And that should be the messaging, that it's open to, I think, so many diverse lifestyles, so many diverse clinical settings, that there, in my opinion, is really the role and the opportunities for so many different types of people, whether you want, a more family-oriented lifestyle, whether you want to do all the traditional call and overnight call for interventional or for ICU coverage. There's a lot of different offerings, and we shouldn't be excluding people that may want a more family-based approach or want other things out of their career at the point of medicine. And so I think, a lot of the messaging around having families, a lot of the messaging around opportunities and what it can look like in both academic, hybrid, private practice. I think there's something for most everyone in cardiology. And I think that the other subspecialties have unfortunately done a little bit better job of messaging that. And some might say, well, the other subspecialties are not as procedurally based, but I would offer up GI and pulm critical care, which are very heavily procedurally based. But GI in particular is very close to parity already.
Thank you. That's, I think, really thoughtful way of thinking about how we can improve gender parity and also just overall representation. So let's see. I welcome anyone to chat, put in the chat any questions. We have a question from Ajar Kochar at the Brigham. He says, terrific talk, Dr. Rymer. Thoughts on specific resources for sites that don't usually conduct research when being included in a large RCT, like navigating IRBs, et cetera?
Yeah, that's a great question. I navigated that within the past couple of years, actually. So it takes a little bit of work up front, obviously, but I think many of these sites, particularly if they have a relationship, not all sites it's going to work, right? If they have really no relationship with any larger medical center with their existing research infrastructure, it's going to be more work. I'm not saying it can't be done, but you have to have some sort of research infrastructure to be able to do these types of studies. And so there are, though, many rural community hospitals that do have an existing relationship. Like I mentioned, like the LifePoint affiliate hospitals within the Duke Health System. I know of many other examples with Kaiser Permanente and other health systems across the country that are able to utilize a central IRB, and then the research work that occurs at these more local sites can then come under the purview of that central IRB. And they can also utilize the research infrastructure that exists at the sort of mothership, so to speak, to help perform the clinical research. You have to get, I think, a little bit creative in how you're doing this, but we've been able to do several clinical studies and include patients from many of those sites under the purview of our IRB, and utilizing our research staff to go out to these sites that don't have an existing research infrastructure.
Excellent. Any other last questions before we wrap up?
Can I ask one quick question?
Please, Sawala.
Hi, great talk. I was curious if you've been able to connect with any unaffiliated regional hospitals that weren't associated with Duke proper, as we sort of think about something similar in Boston. it's challenging because our Attorney General, now Governor, has historically said that because of antitrust reasons, we can't really expand. And so I'm curious if there's like a framework of doing that down in Durham.
Yeah, no, I think the main areas where we have started to, I think it's tough, right, to do the unaffiliated hospitals, but it's the same issues don't exist in community health centers. So I think, you know, even if you can't target patients for studies necessarily at these smaller hospitals that don't have sort of a mothership, so to speak, I think starting to think about maybe simpler studies that involve more remote follow-up in churches and community centers. So phone follow-up with very sort of limited interaction with large medical centers, I still think is a way to go. And I think we'll, you know, obviously we can't do a lot of research in device spaces and interventional spaces at places like this, but we can do implementation work. We can do a lot of studies around implementation, I think, within the community.
Wearables.
Yep, exactly.
Well, thank you so much, Jen, for joining us today. I mean, that was just an incredible talk and discussion on, you know, challenges I think that we face, not just in the PVD space, but across all clinical research. And it was really such a treat to have you join us today. And I thank everyone who's on the line for participating too.
Thank you so much, Emily. Have a nice day. And thank you all. I appreciate it.